So welcome colleagues to this public trust board meeting. Welcome to those in the room and welcome to any who are streaming it. That's my subtle way of reminding colleagues this is a public meeting and it's available to the public. And welcome to Robert from the governors at the end of the room who's observing. And I'm getting fed up saying welcome, but welcome to Maria, who's for whom this is the first board member since she was properly appointed, as it was. Her term started on Monday, so this is the first time she's here as a fully fledged board member, so warm welcome. We've got a full day. Many of us have already had a fairly full morning, but we've got, first of all, public board from here through to 12. We have a half-hour break, subject to all of us, particularly me, behaving ourselves on timekeeping, during which there will be some lunch available. We have the corporate trustee meeting at 12:30 for those for whom that's relevant, which I think is actually, yeah, for the charity accounts and strategy, and then we go to private board straight after that at 1 o'clock. So a bit of stamina needed for this morning. Plenty of really good stuff. I'm a bit conscious of having been encouraging colleagues across the piece to be streamlining papers. I haven't quite been so successful myself in every area for today, so apologies. Some of it though is just the kind of thing that we need to do. We've got a number of annual reports and such like that we need to be able to approve today. But as is often the case for our board, many particularly of the lengthy papers have already been thoroughly scrutinised by committees. So as usual, I'll be inviting the relevant Ned and Director to summarise where the discussion has brought us to here. So although it looks daunting, some of this may not take quite as long as we might think. Any apologies, please?
Yeah, apologies from Margaret Rowe and Simon Ian.
Okay, and any declarations of interest beyond the normal? Then minutes of the last meeting seem to me to be of the normal quality, in other words, good. Yeah, any questions or comments on? No, okay. And the action log, always satisfactorily green. We've got a couple of not yet dues. Last time round we were asking for some stuff on pain medication for November, but it's been shifted back to January, which I think is fine. We're still awaiting a staff story that we'll also aim to take in January. But other than that, I don't think there's any issues arising from the action log, unless anybody's got anything else. No? Happy still? Then moving on to my introduction bit, just to say something I mentioned at the Governors, the Innovations in Health Awards last week. The Trust won 2 awards, one for our Parkinson's work that we've seen quite a lot on, and one on our lung service, which we probably received a bit less on within at board level. It may be worth us learning a bit more, since if we've just won the award, it would be good to understand it a little bit more at our level, but that was a terrific achievement for the Trust. That's all I wanted to raise, because I think most of what I do is covered in item 1.6. So, but unless there's any immediate questions, let's go on to Biju's introduction, please.
Yeah, so you'll see this is month 7 of our dashboard that we give every month at board, every other month, sorry, at public and private board. And I think generally it would be fair to say that the organisation is in a really good state, particularly given what we hear more publicly in the press about the state of the NHS. So you'll see in terms of a lot of our core metrics there, both in terms of finance, HR in general, and our operational performance are all strong. This board table was created just before we got further updates in terms of our cancer performance, so that you would expect to see another green spot on that there in terms of 62-day cancer. It's the first time we've managed to hit 85% provisionally for quite some time. So real credit to the teams there who've worked really, really hard behind the scenes to try and get us to a positive position there. We've also taken up the challenge, thinking more forward in terms of delivery of the government's pledge of returning back to RTT, the 18-week standard, and we're looking and planning with teams about how we do that over the next 2 years in particular. That's not to say, so despite all of that and some of the winter pressures that we see, which I think is starting to kick in now, and you can see that reflected in our A&E performance, we also continue in a lot of our other positive developments, so our capital plan with our building works across and refurbs across our wards, Berwick building plan, that continues. And our collaboration with our partners, particularly the Great North Healthcare Alliance, so for us that is Newcastle, Gateshead and North Cumbria, and that work is also progressing in a very positive manner, and some of that collaboration around patient pathways is now, as shared at governance yesterday, really starting to show fruition. And finally, we end up going into now very much our planning cycle for 25-26. And I think that will start to incorporate the next steps within our clinical strategy after delivering step 1. So particularly when you hear nationally about the left shift, we're starting to interpret that in our own way, what that means for Northumbria, what that will mean for our North Tyneside and Northumberland communities. And that's quite an exciting piece of work that we look forward to building and doing alongside our partners out in community, in the voluntary sector, primary care, and with our local authority colleagues. I should probably just make a nod as well that despite the increase in pressures across A&E, our patient experience still remains very, very strong, as does our staff experience.
Excellent. Questions, comments, challenges? All this data is becoming familiar, although it's being regularly updated. But if there aren't any, then let's move on to the joint report from myself and Bijou. Do you want to kick it off?
Yeah.
I mean, it's pretty self-explanatory, to be frank. So,
yeah. So a lot of, as you can see in the report, a lot of my time and obviously considerable amount of time at Paul is spent externally in terms of promoting and supporting the trust and the direction of travel of the trust externally. A large part of that time, and I've just alluded to it in the dashboard there, has been spent with regards to the development of the Great North Healthcare Alliance, and that has, I think that's really started to show fruition now. We had a very positive governors meeting around that last night as well. The usual engagement with local authority, chief execs, continues, and that is, I think, very important in terms of particularly as we start to discuss some of the left shifts, but also the view that we are we need each other. We rely on each other in terms of delivering our services, so those positive relationships are encouraged at all levels across the organisation. And then at a national level, we continue to provide insight into the strategy with a small group of reference chief execs, which Northumbria is part of, that we help to advise, support NHS England on, and also from several board meetings for NHS providers, of which we represent the North East, alongside chairs from County Durham and Darlington and Chew. Was it to add anything else there, Paul?
no, I might add something myself, but let me just check a few questions to Bijou about her engagement in particular externally. And from me, this report is becoming usual, summarises the headlines of what's come up through governor constituency meetings, but all of those issues are one way or another being addressed as they're raised. I do think, though, we are seeing a cross-cutting theme about parking and transport, which we will come back to when we get to the board walkabouts, where we hear the barely disguised rage of one of our Neds. Spent 75 minutes trying to park at one of the hospitals. And I'm beginning to think it's not just a matter of us looking at each hospital once one at a time. I really think we need a more kind of systemic look at our approach to parking and to transport. And I'm not quite sure what the action is. I haven't prompted Bijou on this before, but we can maybe just flag. Paul, come on in.
Just on the wider transport issue, Paul, just in the process of agreeing a review by Newcastle University, so there's going to be a joint piece of work with the university to look at logistics, transport, etc. across our footprint, which may help us, or hopefully move to a more efficient use of transport and also how we use car parks, etc.
Well, that's encouraging. I saw that reference in the response to Healthwatch, and I just wasn't sure about how wide it goes. But if you think it goes wide enough, then that's great. Let's make sure that we look at the learning from that and feed it back into governance as well. Steve.
Just wondering whether or not we're contributing to the Combined Authorities consultation on transport, because that's going to be quite a thorough region-wide approach. Some of our transport issues will be region-wide.
Russell, Paul,
I have seen that mentioned in some of the emails that have been up around. Steve, so I'll pick that up with the guys.
Ross, anything to add on that?
Just to see, we've had a couple of early calls on that subject with the Combined Authority. We've got another call next week to look at how we can trust can input into that.
Good. Okay, I think that's going to be an important topic for us. And in particular, as we develop our next strategy, if it's not somehow an enabling strand somewhere, we'll be missing a trick. Good. That was all I wanted to highlight from my report, but it has included updates on some of the regional meetings that I attend that I don't otherwise report in, so I'm happy to take any questions or comments. Thank you very much indeed. Let's go on then into patient and staff experience. And is Mike, we've got Mike here, yeah. Oh, sorry, Mike, you were hiding behind that insignificant blockage of Bijou. Thanks. Welcome, Mike, the Guardian of Safe Working Report, one of your regular reports.
Hi, thanks. I think there's a compliment in there.
It didn't quite come out that way.
Thanks for having me back. It's nice to be in this big room, although I think you need opera specs to see down that end of the table. Hopefully this will be quite a positive and fairly short report. Things in the world of safe working are at a nice sort of stable state at the moment.
24th, 25 rather than 23, 24, isn't it, Mike?
No, that's last year's numbers.
Oh,
no, that's this year's.
Okay.
You're absolutely right, my problem. So it's 140 this year, so you're right, 24 to 25, which is a rebound. We had fewer ERs last year, no particular reason, and it's gone back to the year before numbers. That's what we're heading to this year. So there's a stableness to the number of exception reports we're getting. It works out about 220, 240 a year, so about 20 a month. Majority is still in the medicine business unit with no current hotspots, particularly no hotspots in medicine. Majority still resolved with time off in lieu. We had a little hotspot or a blip in trauma in orthopaedics with a lot of exceptions in this period of about 2 or 3 weeks. When we drilled down into that, it was 1 or 2 trainees doing that, and it was a reflection of an error in the trauma and orthopaedics rota, where the start time on theatre days was earlier than the published time. This is something we'd seen in obs and gynae as well, and it's when we try and build in some flexibility to the rota, because there are days they come in earlier, and capturing that's quite challenging. So we put together a meeting. I'm going to meet with trauma and orthopaedics rota team and the clinicians there to look at how we, and with the resident doctors, to look at how we get this right going forward. It hasn't impacted particularly on payment because their hours were worked out correctly. It's just a bit of fine tuning of the rotas, which is something we need to do with obs and gynae again, because the same issues have arisen again with that team. But it's really fine tuning of those rotas, and it's just a reflection of the difficulty capturing work scheduling in the new contract, and well, I say new contract, in the current contract, and it's something we're learning as we go along. So I don't envisage that being a problem going forward. We just need to get those rotas right for next time. So not much else to say about exception reports. We don't have any discouragement. We haven't repeated our discouragement survey yet this year. I think we decided to do it 2 yearly because it was such a good result last time, and the trend was less and less discouragement over the last 5 or 6 years. Brings me on to the postgraduate, or now resident doctors forum. People will remember we had poor attendance through the pandemic, which was to be expected, but that continued after the pandemic, and with a lot of work in 2023, some funding from postgraduate team, we managed to improve attendance significantly after doing all that work. And it has improved to what it was in the pandemic, but it's tailed off a bit in the last couple of forums. We had 13 resident doctors attend in September. We had managed about 20, and our best ever is 32. So what we've done about that is we're still trying to advertise it better, engage. The last time the Safe Working Administrator actually went to every ward in the trust and tried to drop in on the wards and ask doctors to attend. We still only managed 13. We still have a free lunch, so you would think that would work. It's not a great lunch, but it is free. So I did, at the last regional meeting, I asked colleagues around the region as to how things were going in our regional comparators. And I was interested and disappointed and happy all at once to hear that they also have poor attendance at their resident doctors forums. Durham and Sunderland, single figures. The Let, 0 doctors. If you look at Newcastle as our nearest competitor, if you like, or comparator, Newcastle have about 20, but they have 1,000 or more doctors, whereas we've got 370. So doctor attendance per doctor in training, we're doing better than them. And South Tees, they also have about 20 with about 500 doctors, so they're about the same as us. So South Tees are about the same, Newcastle are worse, and everywhere else is worse. But we're still going to try and work on that. I'd like to get us up to about 20 or 25 would feel like a good number. We've put in, we now meet, we have a pre-meet for the doctors, we have a chair who's a resident doctor, we've got a doctors representative model where we have representative doctors who are doing it as part of some of their training, and still we're just struggling to get those numbers up. Any ideas greatly welcome to improve this. Pizza might do it, but pizza seems to do it, and we don't have pizza for lunch, but we'll see. The drop-ins continue, so every other week I'm in the mess here at NSEC, and we do see good engagement there. We sort of dovetail a bit with F1 training, and we get some things raised through there and keep the visibility of the role up, which I think is quite good. I've had some informal feedback that the doctors here at least know who we are, and they say that in other trusts they don't even know who their guardian is. So that was good, which moves me on to rotas, which I've touched on already. On paper, we're doing great with rotas. Our rotas are fully compliant and have been now for 4 years. We've still got some relaxation of the rota rules until Gold Command tell me to stop that relaxation. I'm not going to, because it gives us a bit of flexibility. It's probably a good idea through winter pressures anyway. There are gaps, of course, there's gaps. We struggle sometimes not being told about the gaps in a timely fashion by the Let, but the gap management's pretty good. Of course, there's grumbles, of course, Christmas is coming up and people are not happy with some of their rotas, but I think the rota coordinating team are doing really well with that. I've just set up some work with the rota coordinators. I have a regular meeting anyway with them about 3 or 4 times a year, but we're doing some work to try and map out what would be good rota planning, and thinking about putting forward a chart of semi-based on the BMA guidance to try and get some consistency across the trust in how we do rotas, because it can be a very different experience depending on specialty, or even within a specialty there can be variation. I'd like to see, so if you want annual leave as a resident doctor in Northumbria, you know what to do, and it's the same wherever you go. If you've got an issue with your rota, you know where to go and how to escalate things. So there's some positive work going on with regard to that, but it's work in progress. And that's probably all I've got to say.
Thank you. Questions, comments? It sounds like the issue of the rotas for trauma orthopaedics should be simple to solve.
Yeah.
Are we able to receive assurance that that's been sorted out?
Yes, we've been working very closely with the team. I think Mike raises a really good point about theatre, because obviously they go into theatre very early.
Yeah.
That's part of their training, part of their experience, so we need to come up with a plan that's going to make that fit for purpose and work for everybody. It's in hand.
Okay.
Thank you. Thanks, Mike. It's always really good to read. Can I just ask a general question about the morale of the doctors? So obviously there's sort of a direct link with engagement and the attendance at the postgrad forum, but we've had some discussions about health and well-being. So just a general question, I don't know, how are the doctors in terms of morale and well-being?
Well, it's a great question, because when they come to us, their morale might not be that high, but they don't come to us that often.
Mm-hmm.
So if you gauge that temperature, they seem the morale seems pretty good. And I think, again, there's two parts to that. There's the morale of resident doctors in general in the NHS, which I think is still poor despite their strike having been resolved. There's still talk about working abroad when you talk to them. Drop-in's really good for that, because you get them at lunch. It's not, they haven't come to see me, we've gone to them. And in general, the morale, I think, in Northumbria is pretty good. I hope that's my gas, but it is pretty good. And most of them don't have issues. So you're asking, have you got any issues with your rota, any safe working issues, any issues? None at all. Things here, if it's worked elsewhere, you get things here are much better than wherever. With the F1s and F2s, you get a little bit of grumbling, but it's probably new to work grumbling, and specific rota grumbles, and Christmas being a particular grumble.
I'm just wondering if we could use maybe one of the postgrad forums to just highlight our offers in terms of wellbeing in the trust, because obviously the let doctors move around, and I do hear some grumblings of not being able to access my, so I wondered, Mike, if that would be all right to just use it for.
That would be fantastic. I mean, the other way to do that, a good place to do that would be through foundation panel as well, because they tend, the foundation panel, foundation forums better attended.
Right,
and
we'll link it.
But both would be great, yeah, just let us know, we'll put you in whichever one you want.
Is it a meaningful performance measure to know how many people are attending a forum every now and then? It kind of doesn't feel that strategic to me.
Well,
is it a statutory requirement that we have one?
It's a requirement we have it as part of the contract. We have to have it, it's either 3 or 4 times a year. There's no statutory guidance on how many of them have to attend.
Okay. It's just interesting. I mean, in a presentation like this, I'm much more interested in the reply you gave to Kate than I am in the detail about how many people attended a forum. But for the reflection teacher reporting. Yeah.
I don't worry too much about the numbers, but if you get to a certain degree of none, it's a trouble. Yeah.
And another quick point on the reporting, for which thank you very much, Mike. Last time I was asking for comparative data, how we got on compared to last year, and I found it, but I had to dig a little bit. So I quite like the summary report when it starts off saying 139 hours today in 2024-5. I'd quite like there to know the comparators of the year before, and then any trend data. And what I'd love to see also is comparative data across the region as to where do we sit not in absolute numbers, but numbers per 100 doctors or whatever the more comparative would be, it would be helpful. And maybe you kind of already know. Are we kind of there or thereabouts, or do we have more ERs than most or less?
It's very variable, and it's very hard to get the data. So every regional forum I've asked that we share our reports with each other,
Okay.
and I send mine out, and no one sends them back. So,
Well, if we can't do that, that's fine, but it would still be interesting to get it.
so it is very variable, and it's hard to interpret. But you're absolutely right, you need to know the number of doctors as well, and that's hard to get off other people as well. But I think we're probably fairly average, but the average in a very broad range.
Okay. Thank you very much indeed. Anything more on Mike's report? Always a pleasure to have you here, Mike. Thank you very much indeed.
And everyone.
And shall we move straight on? Jeremy, you're going to explain to us why the figures for flu and COVID vaccinations are not enormously high.
Well, I don't know that I've got a explanation. I can share your disappointment, Chair. The COVID vaccine didn't arrive at the same time, so we have had slightly less vaccination time, although I'm not convinced that that is the only reason that flu is, and it is always a struggle. It isn't compulsory. There have been conversations at a national level about whether we would make flu vaccination and now COVID mandatory, but they don't. So we continue to go out to the vaccination teams, and there is a certain degree of vaccine hesitancy. The junior doctors are a group that are difficult to get to. There are alternative sources of vaccination available, and we rely on the staff reporting when they've been vaccinated elsewhere to us for that information. We continue to work as hard as we can with another series of videos with the same message now, because it is disappointing, and we are just about to enter the flu season.
Thank you. Any comments? Particularly any helpful suggestions to overcome the data? Katie?
I'm not sure I have a helpful suggestion, but just to say that it was discussed in detail at People and Culture Committee yesterday, and we're thinking through sort of the strategy for next year, getting staff side engaged much more and trying to help get vaccine numbers up, and also just thinking about being winter safe and the impact of that on our bank as well.
So I do. When we had local vaccinators who were embedded in the wards, I think we did have a fairly reasonable system about trying to get wards and areas to think about that, because there is absolutely no doubt that it does improve attendance at work, and that must have an impact on staff morale and everyone feeling okay. So
Andrew?
I was just going to mention, by way of a good news story, when I got vaccinated, I just couldn't think of a single thing that could have been better about how, especially around the kind of comms aspect of it. So I kind of said, yes, I know all this, don't worry. And she totally ignored me and told me all the myth busting. I felt fully myth busted on the way out. I can't think of a single thing once you've got someone in that conversation, and also getting into that in a totally flexible way that could have been any better. So I think just emphasises the People and Culture Committee conversation yesterday around it all being about how people get into that process. It feels like the bigger challenge.
Okay, Richard.
So the interesting contrast for me is a couple of weeks ago, a few of us were at the participation group events and had a presentation from the school vaccination service, which is an unparalleled success story for this trust, and the phenomenal work they're doing at driving up engagement in traditionally hard to reach communities. I'm just wondering if we can do some work, perhaps leveraging between the two teams, to see if we can some ideas around about engagement, because they seem to have some very creative ways of dealing with the issue.
Yeah, interesting indeed. Okay. We're asked to note the report. I think in addition we're noting our continued disappointment. We're noting that PNC have got developing a strategy for next year, particularly with the potential to engage with staff side at an early stage. we've heard that actually once you're there, the feedback we're getting is that the service is really good, and the suggestion that we see what we can learn from the school vaccination success that we've had. It'll be good to move on from there. Thank you very much indeed, Jeremy. And Joe, we're into your slot, the patient and staff stories, and it's a really, really positive one to begin with. I love positive stories as long as we remember that we also need the negatives, but previously I think we've had some proper challenge in this one. But this one seems to be saying we're doing a great job in the various areas, yeah.
Yes, thank you, Chair. Yeah, we do try to bring a good balance of stories. So this patient and staff stories for board today from our stroke services, so from across the 3 sites, so Hazo in NSAC and our 2 wards in North Tyneside and Wandsbeck. Unusually I want to start with the staff stories. I normally always start with the patient stories. There is a reason for that, which I'll explain. So our staff stories are 3 members of staff. 2 are really long established members of staff. We've worked with 1 member of staff over 30 years, the ward manager, and 1 is a ward sister, and a relatively new member of staff, one of our healthcare assistants, and they all talk beautifully about their commitment to the patients that they care for on each of their sites. They talk about the complexities of a stroke for a patient, and not only the physical aspect of it, but the emotional aspect of it, not only on the patient themselves, but also on their family. And I have to say that I witnessed that when I used to measure patient experience on our ward in North Tyneside. It can be a very traumatic time for both families and patients. They talk about the importance of team working and the MDT and how that's crucial to the recovery of supporting patients through that journey of their rehabilitation. And one of my favourite words, I think it's the ward sister or the ward manager, refers to the family on the ward. So they see themselves as a family and they're proud of the work that they do, and they get no greater joy than seeing their patients progress through their rehabilitation and eventually to go home. So I think that all 3 stories were absolutely fabulous to read. They do talk about the challenges, so when they have situations where they're short-staffed, it can be more difficult, but they always strive to deliver that care to what their patients need. So the reason that I've decided to do the patient story second this time is because I think the patient family story absolutely demonstrate what the staff say. So the staff talk about all those things, but then the patient stories describe that and what it means to them. So the daughter of a lady who had sadly had a stroke, she talks about, she witnesses the teamwork and the difference that makes. She how involved she felt in the whole process. Also have to do a shout out to our colleagues in NIAS, because one of the patients has mentioned the expertise and the care that they received in the ambulance on their way into NSAC, and similarly our colleagues in the emergency department in our hospital here, the care and support that they were given on their journey through onto the stroke ward. So I think through the patients we see all of the things that the staff talk about that really matter to them in terms of the care. It's demonstrated through the stories that the patients feeling emotionally supported, feeling physically supported through their care and their rehabilitation.
Lovely, eh? Questions or comments? Yes.
Probably just to comment. So I was an operational service manager when Joanne Gilroy was a ward sister. So she's somebody at Wandsbeck Hospital who has well and truly served her time at Northumbria, and I would say, which is a real credit to her and her team, that ward has always been a very, very strong ward in terms of the sense of looking after not only her own, she talks about the ward team, but also how they treat patients on that. And that's even with the model shift, when we split the service with hyperacute stroke at NSEC. We often talk about what makes a good ward, and that clinical leadership from the ward manager is really, really key. And I think that's something that Marion and the team have worked really strongly on, in ensuring that our ward managers are very strong, because they're the ones that fund what that service then is to our patients as a consequence.
Okay, good. Let's just move on from there to the more data-driven section. Jeremy.
Yeah, so our report to board, so I'll just do some headlines. So in terms of patient perspective, which is our external measurement for Q2, our inpatient and outpatient, and day case, the majority of our patients across the quarter rate their care as excellent. When we look at our inpatient, we remain within the top 20%, in particular for 36 of the 40 questions that we ask our patients. If we then drill down by site, we see that NSEC in particular does not sit within that 20%, and we see a decline over time. In terms of focusing up our area for improvement as NSEC as a site for our inpatients, our patients tell us it's around the waiting time, so the waiting list to actually be admitted, the wait for a bed, and then in particular around discharge planning in the main are those key areas for focus for improvement. Our patients, we see a strong performance and we remain within the 20%. When we look at emergency care, again overall, we're within the top 20%, which is over 78% for our score, and we've seen that NSEC has returned to standard variation. However, we know that they sit below the 20%, and our area for improvement within ED is waiting times and pain management. I've just been speaking to the team this morning, and we're looking at how we can actually work on those areas, in particular looking at a project around pain management and some of the questions helping to drill down more into the pain management area with our patients and understand their experience in more detail. The real-time report for ED reflects similar, the waiting times and for pain management, but the other domains, so 8 out of the 10 domains sit above 9. We have the November report just came out yesterday, the final one, and we've seen an improvement in waiting times from the one that's in your paper. If we move on to community, we had 3,395 patients respond for Q1, and just 126, although each of those is a patient, we have to remember, reported a negative experience. In the main, that related again to waiting and to access, to coordination and care. But on a positive sense, patients report that they feel really well emotionally supported, and the respect and the dignity that our staff afford them is part of their positive experience. In terms of our AI technology, put my teeth back in, we've given you a bit more information this time. So what we've been giving you is a line graph over time that compares us nationally, both nationally in England and regionally. And this is what our patients are saying in the public domain. But what we've given you this time is we've broken it down into the key domain areas and given you the 5-star rating. So you can see that Northumbria has a strong performance in terms of the 5s, the 4s, the 3s and the 2s and the 1s when we compare nationally and locally. And that takes us down to our staff survey, so hot off the press. As a trust, we're sitting at 68.3%. NHFM, we're sitting at 67.2%. MPC, amazingly 76%. Go MPC. And Bank, I think this is fantastic for Bank, just over 50%. And I just got to acknowledge some of the work Claire and her team have been doing, which is amazing.
Yeah, we got today and tomorrow to get it up to our target of 70%, haven't we? Yeah, okay. Great report, terrific. I agree.
I just wanted to pick up on the pain point, Jo. Yeah. And we've talked about it before in the ED, and Alistair rightly picked up that there's a very different thing between chronic pain and acute pain, and how much we've done on that, because we have talked about it before. For me, waiting is what waiting is, and it's a very personal experience, as is pain. But if we've got people sitting in pain in the ED while they're waiting, that is difficult. But understanding if that's something that is a now issue or is an all the time issue is quite important as well, isn't it?
Yeah, thanks Ruth. So I had a chat with Alistair about how we might represent that in the report. So I've talked to Paul, and Paul's in the process of changing the spreadsheet so we can delineate the pain between that acute and those patients that have had chronic pain over time. Again, the conversation with the team this morning was exactly that, what's in our locus of control right now, and it is the pain management. So that's one of the things, there's some of the band 7s within the department are looking at that improvement of patient experience, so they're going to link with me to look at how we might also drill down further into the pain. There is a quality improvement project that the team are working on around pain management. So again, I've offered more support from our team in terms of management of the patient experience within that quality improvement project. So we're going to link up, and I think we've decided today that our focus in this first stage is absolutely going to be pain, and we're going to add questions to the real time from the team's perspective. Because what I was saying to the team is, this is absolutely a tool for us to understand our patient experience with, but it's also a tool for them, and it has to be useful for them in terms of where they focus their improvement and what's helpful in terms of what we're asking.
I think as well, when you get the full report in the narrative that is provided, it's quite interesting because it's not always reflective of the scores. So both from a waiting time point of view, actually pretty much most people say, oh, it was really quick, didn't have to really wait very long. But also on the pain management element, it's more about, I asked for pain relief, somebody went off to get it, but then it took 2 hours for it to come back, which I think that is something that is possibly reflective of the busyness of the department, but that is something we can impact on.
Alistair?
So 2 comments. First, going back to the pain question, I think by looking at how long people have had pain, we've got some cut-offs now going in, so people have had pain for 3 days or so, it's probably fair to say that should be being addressed within ED. People have had pain for 3 months, or we weren't, so that we're using time as a way of delineating the acuteness of the pain. So it's quite a simple measure, but actually will be really accurate with that. The other reflection I was just going to say is, last week I was doing some work with NHS Wales, who are in a difficult spot in the north. Their staff participation in the staff survey is 12%, and they were struggling at how to get it from there. And my point was, we just take 68%, trying to get to 70 as okay, that's the norm for us. And there are other organisations that would bite our kind of arm off to be there, and they were very genuine about how do we get this above 12. So it was more just, it kind of, sometimes we're in this bubble where we kind of forget where other places are at times, and I think it's just important sometimes just to kind of track back to some of the great work that's going on, because it doesn't happen by accident.
Good. We're asked to note the report. I think that let's start with noting the staff performance in response. It would be even happier if we do hit the 70%. Alistair's point is a good one. In another trust that I know something about, we're really, really proud now because we've got over 60%, which is a massive improvement for that trust, and will probably put that trust in second place in terms of the number of responses nationally, behind Northumbria, of course. Sorry, Ruth.
Just one other thing, Joe. I always look at food because we know food's another one of those difficult issues, and Marion knows it's on my list. But and what I see is sometimes you see a low score and the next month it's a high score, and I know there's very personal opinions, but the children's unit, which scores brilliantly for everything, scores terribly on food for 2 months running, and that's, if it happens more than once, I think that's the theme, really.
Yes, I totally agree with some meeting with Brian Cowling. I think it's definitely before Christmas, and we're going to be having a look at food, but in particular the children's unit.
Okay, so we're noting the response to the staff survey with pleasure. We're noting that we're starting to get on top of the pain, or at least we're starting the process of trying to work out how to get on top of the pain, the responses on pain, because it does feel like some of that should be within our control, and we've been seeing that data for long enough to be saying, come on, let's get on with that one. And we've had the reminder of the issue about food within the children's unit. But with that, we're noting the report as requested and moving on. And this next one is the Trust response to Health Watch. And the board asked us a little time back, and when we were kind of noting the quality account, and the quality account process requires feedback from a range of key agencies. And Health Watch produced feedback saying, oh, really good stuff, lots of good stuff. Here are 3 things we want to ask you about. And so as a public board, we wanted to make sure that we were paying attention to that. So we asked for a summary to learn how we're doing it. And Chris, this is the outcome. Do you want to just introduce it for us?
Yeah, sure, thank you. So as you say, this was the Health Watch response to the quality account. And as you mentioned already, Chair, that the overall feedback from them was positive, but with the 3 areas where they've asked us to look and to remind us that the feedback they've received from the patients we serve was that we could potentially be doing better or be doing differently. The 3 areas in question are around community services and about more clarity about how you access the service, about referral processes, waiting times and what they can expect to receive. I think it's important to say at this point on that it's not, I don't think it's not that we don't provide some of this information. It might just be how we provide it and whether people know where to access it. I think it's probably the key bits of work that we need to work collectively on. That said, we could provide it in several different forms, several different ways, and if people still don't access it, they still won't know that information. So I don't think this one is one way you can say, oh, actually, yes, we've done that, we've ticked that off for 100%. We're 100% on this one. It's a bit like the painting the fourth road bridge, isn't it? It'll be always looking back at it, because there'll always be a certain number of people that don't know where to access that information, but that's something that the teams are working on. The second one was around information on discharge from hospitals. Again, I think it's similar, that we do provide in numerous ways and numerous different ways of providing that information to patients. But again, it's one of those where we need to take that feedback on the chin and go, well, what more can we do? Is it that the way we're doing it and the timing we're doing it and the formatting we're doing it, is that not quite right for certain sections of people that we provide inpatient care for? So again, I know Marion and the team are working on that, particularly for the surgical end and elective end of things. And the last topic was around travel and transport, which we've already touched on in the meeting. And that kind of is around, I guess that's 2 things, isn't it? It's around the patient transport that we provide if we're transferring patients across, and mindful of if we're asking patients and relatives to travel to different sites, that there's transport available for them, either through PTS or through our partners. I think some of this comes back to how our partners are doing, something about local councils and how they don't commission public transport and they do it, but kind of how our local public transport partners are also putting on services. And I think the other thing just to say on that that is in our gift is around how we kind of manage our services. So I'm thinking in the outpatient setting, how we can have PIFU, so we're not pulling people into different sites when we don't need to, how we have more virtual appointments, which our rates are comparatively good, and how we can kind of promote those virtual ways of working, so we're not asking people to travel unnecessarily. I don't know, that's kind of a summary. I don't know, Marion, anything else to add on that?
Marion?
Just really to reassure everybody that, Chris and I have discussed this and we have got various people working on this. The admin board has sort of come back to life again. It's sort of stalled over the last few months, and that meeting was yesterday, and these very things were discussed at it. Just to see how we're going to make sure the communication is right, and particularly the discharge information. That really worries me that we've not got that correct, because that makes people not have confidence in being able to go home or whatever. So the team are absolutely looking at that, and very happy to feedback that at a later date, but they have got a plan in place.
Good. Richard?
First of all, I think it's really good to see this report.
Yes.
Organisations like Health Watch go to the trouble of giving their views, that we should be responding back to them. The one I'm uncomfortable with, and I would like to see probably a follow-up discussion, is on discharge. I've experienced discharge letters, and I know they have a lot of complex things to do. They need to get some very precise information back to primary care, and it's important that that is very precise. And then they're telling the patients what's happening to them as following their discharge. And that sitting in one letter does not make for an easy read. And several pages, including all your CT results, is not an obvious way of communicating with a patient on what's been a difficult experience. You know, I compare that with the consultant's letters you get after outpatient appointments, which are usually extremely well crafted, very clear and very concise, and then I compare it with the discharge letter. And I know it's very important stuff needs to get to the GP, but whether they can split them and get those two streams differently, I think it needs a quite big rethink, that one.
Jeremy?
So part of the issue is there is a specification that isn't completely within our gift.
Yeah.
So there is a clear expectation from primary care how those how that summary information is set out, and I have to say that is part of the difficulty that we've got. One of the things that we can really think about is how we can give patients information about where to come to when they've got problems and follow them up. And I think you will see, as people leave hospital, there's quite a lot of attention paid verbally by staff to those things, and that perhaps the discharge letter, because it does need to be a lot of things to all people, perhaps isn't the best location for some of that really key information about if you've got a problem, this is what you do about it. And I think that's probably, we could be clearer on that information, and we could, and I would encourage teams to do this, to actually put in phone calls to patients in order to find out what their needs are. That goes on quite a bit in surgery, and is a very, very, very valuable thing to do.
Richard, are you satisfied with that response, or would you still like for us to have a mechanism for a more detailed discussion on the discharge process as well as letter?
Yeah, it's sort of feeling for me a bit like a board development topic, that we should take a bit of time just to understand the whole experience. I might talk forever about getting meds being discharged, but I think there's something about the whole feeling that just needs a bit of a holistic look.
Well, there have been a couple of kind of safety-related issues emerge around the discharge process over the last month. Last year, we might want to sweep that into a discussion somewhere. Yeah. Can we take it away and think about it? But I think we'll be. Sorry, Alison.
I suppose two observations. One is that there is a real time on discharge around safety, and they are normally completed by junior doctors or resident doctors, we should call them that. So they're often by the most or the least experienced members of the team, partly because they need to be out there within 24 hours, as opposed to an outpatient letter which is by a senior member. But there is a bit where I think that the bit you would hope throughout somebody's inpatient stay there is a dialogue that's going on about their care, but what's often not clear is the plan on discharge for people, because there should be participants in their care during the stay, and having a written account of what happened while you stay is probably less important than what are the next steps for you in your care. And I think that's the bit, because if we try to do everything, we'll end up failing. But if we get a particular focus on the follow-up for you as an individual, the next steps in your plan, I think that's something that would be really worth a focus on, rather than a focus on a more detailed account of the narrative while you're in hospital. Because actually, nursing staff and others are great at having conversations. We don't need to then recapture that, as opposed to what the plan is. And I wondered if it was the plan about where you go next that is the most important for people on discharge.
Ruth.
I don't talk about discharge.
Sorry, then just tying that up. We'll organise a board development session in due course to look at it in the round, not just the letters, but the process and the planning process. Happy to move on from discharge.
I was just going to talk about community, because the bits that come up in the community that are quite similar to the conversations we have a lot in governors.
Yeah,
so it's quite a good representation, because it's obviously what the public thing is. There's some of that is education. So we've had people in from podiatry and MSK talking to governors. And part of that is the public understanding what is a medical service and what is perhaps a slightly more cosmetic element of the service. And it was really interesting to have that information from the podiatry team about the fact that you don't just come and have your toenails trimmed. This is about people with life-changing diabetic problems, for example, and they are always going to be prioritised. So I think there's a little bit about on us about public information about these services and what people can expect from them that we need to do. On the counter to that, the wheelchair services is not a choice, and it's really difficult, and we've got it in our eye line. It's been raised a lot in Assurance Committee that we know that this is a problem and we do have to improve it. I'm going for a meeting with the new wheelchair manager to talk about it, because it is the difficulty that people are not getting a time frame. And you know yourself, if you know you're waiting for something and you know there's a time, that at least means you know that you're being dealt with and you're in the service. And I think this approach where we haven't even been giving people a time scale is really difficult. Honestly, you're not making a choice about having a wheelchair, you have no choice. So I do think that's the one for me out of the community bit, that some of it is about us telling people what's sensible and appropriate, and that bit is us about, and I know we've put a lot of effort in, I know we've had a lot of recruitment, so I really hope that we're going to see a big turnaround in wheelchair, because it is a difficult one.
I'm with Ruth on this, but both on the general, it really struck me with the comments from Healthwatch. They align almost completely with issues that have been raised in government constituency meetings, which gives it a sense of validity. And so, whilst I'm really, really pleased that we've responded overall, I kind of think if those points come in, we want to not just be appearing to be simply explaining what we're doing, but explaining how we're going to try and make it better, so that by next year they won't feel the same need to be providing that feedback. And so there's something, and I think that issue about the contact information is one where we just need another look. I hate raising yet another issue for us reflected somewhere or other, but we need a bit more evidence in, first of all. It may be interesting, Joe, for you to do a little trawl of what data you've got, but a lot of people say that they're having difficulty. Not say directly to us that they're having difficulty in accessing individual community services, that we could just find out if there's anything more in that. And for me, the same applies in the third issue of transport, where the bit I'm most keen on is the second paragraph saying that the Trust Public Health team is currently conducting an in-depth review of healthcare travel to health inequality lens. Because that appears, I mean, Richard will be nodding here, every Berwick Governors meeting, we go back to transport and how do we get there, why are we still giving an appointment at 8:30 to be attending at NSEC or whatever, when even patient transport doesn't get there, but nor does anybody else. And I think we need to be able to be seen to be taking that forward. And I'll bring you in just a second, Alistair, but my overall conclusion is also that, has this response already gone to Healthwatch? There should be a cover that says thank you, I mean really thank you, and saying we're taking it seriously, it's been discussed at board, public board, and we're taking action forward on each of the areas, in addition to the information given. Alistair?
I was just reflecting on the comments. I just wonder if there are two issues here. One is eligibility for NHS services, and I think that's a different issue from access, because you can say, well, I can't have access, but if you're not eligible, we never should be providing access, and that includes transport, because there are people who aren't eligible for NHS-funded transport, and there are people who are, and that's not to do with rurality, that's to do with the set of the national criteria around that. And it's the same with podiatry and other bits. And I think if we just focus on access, we actually potentially perpetuate the confusion, because a lot of the confusion is, I want my nails cut in and I can't get them done by podiatry. It's not an access issue, it's just you're not eligible for that service. So we probably need to focus on both where you are eligible, we need to make sure you've got good access to it. But where you're not eligible, we need to be really transparent, not just locally, but as part of the NHS, that that's not an NHS funded service, and people get that for cosmetic surgery, but they don't get it for cutting their toenails. And I think there's a danger we confuse both, and actually that potential just makes the problem worse.
Very fair point. Any more for any more? Warm welcome of the report as drafted. Strengthen it in terms of the thanks and the recognition that we're using it as an improvement process. We want to take on further and explore further some of the issues around discharge, some of the issues around sharing information, and in due course the issues around transport, where I wasn't really talking about patient transport service, it was about a patient that wants to get their own way to appointment, it's bloody hard to get down to one spec line by 7:30 or 8:30 or whatever they're being requested. Did I see your hand up, Joe? Sorry.
Well, it was just really on that last point, Chair. We had a conversation at the patient charter meeting, and I do think there are some of the ways that we book appointments and our systems for booking appointments that don't properly, where the feedback we were given is that it'll be a great aspiration, but we will need to have a look at some of our admin processes and how sensitive they are to the needs of patients. And the example you gave around geography is a really good one.
Good, thank you. Anything more that we were asked to note it? I think we've done a bit more than note it. We've improved it, or we've asked for some additions, and we've agreed a fair series of actions to follow through on some of these issues. Thank you very much indeed, Chris. That's a really good piece of work to get us together. And next up, we're into board walkabouts on this section. Good. Let's start then. North Tyneside, Andrew.
Yeah, so Alistair and I went to the urgent treatment centre and deliberately turned up unannounced in the evening. We thought it would be good to get a realistic impression of what it was like in the evening. I think we were welcomed. I'd say that genuinely in the sense that they were very in the sense that they really did appreciate us turning up out of hours and just saying, like, tell us how it is, and really committed the time to talk to us, and were very, and that was brilliant, but we were really conscious that it was a very busy evening, and so I think that's the sort of mixed blessing of going out of hours. You see it how it is, and that's good, but then also that it was clearly a challenging time for them, so I think it's something we should keep doing, but it was certainly something where Alistair and I didn't really feel like we wanted to hang around when they had quite a lot to be getting on with. So there were 24 patients in the department. They had 8 appointment slots available, and it actually looked quite calm considering how full it was. So it was reassuring, but also it was busy. And they did flag that one of the things that had really helped was that by booking slots, they were able to send some people away for a little while, so they didn't just have to sit in the waiting area and then come back, and that was helping at least get people through and keep it calm. So I think that was working well, and it was good for patients' expectations as well. So we had a bit of a conversation about where the pressures were around staffing, and I think Julie, who was the nurse practitioner in charge, was really very positive about it and said, we've got a GP on till 10 o'clock tonight, that's enough. It really helped having a triage nurse on. She did say that it was the nurse, having sufficient nursing staff was the challenge. And so on that day, they put the call through to NSEC to say stop sending us people at 3 o'clock that afternoon. And I think we were having this conversation, it was probably about 7:30, I think, by the time we were having that conversation. So they'd already said stop sending us people, but it was still possible that 111 were directing people there. It's kind of hard to know in a way. So we had quite a big conversation about how patients were moving through the system, and I think both of us left feeling like we wanted to understand a bit more about the data about who was moving where, and I think we saw for the first time in the issues update governance last night, the charts about starting to show which numbers were moving where in connection with the front door streaming at NSEC, and I think that's the kind of thing that we might need to get into a little bit more to understand some of what they were saying. So I think that's probably something to follow up on. And the actual space that they were in was working fine for them, but it looks like an old A&E department now, which I guess is inevitable. And it was good to see that they have got some space for staff to take a break in, and it was working for them. It looks like what it is, but it was working for them. And they did have some suggestions, like one area in particular was around having a waiting area for patients with sensory needs, which I thought was quite interesting that they raised. But they were pretty happy, I think, with the environment that they were working in. I asked about digital things, as I always do, and there was a sort of kind of it's okay, like an unenthusiastic sort of system one's all right conversation. I think that the only The only sort of issue I could get out of was around primary care records for patients whose GPs don't use System 1, which makes very well understood as a problem. Not that that's very satisfactory, so I think it was kind of, what's I writing this? They spoke about it with a sense of inevitability rather than enthusiasm, but there were no sort of criticism to pick up on really. So it just I felt like they were doing a brilliant job, but just you could feel the pressure, I think, of just the number of people going there, and the big thing that they wanted us to pick up on was this sense that people still, in the area, still think that they can just walk up there. And a real sense of, I don't know how fair this is, but a sense that the trust could be doing more to help the local community understand what the facilities are there and when you should go there, and to help people get to the right place.
Alistair, do you want to make any response, any addition?
The only other bit that I thought was quite interesting, which has set off the whole new piece of work, is that they cited the number of post-op wound dressings that were coming through, which I wasn't aware of, and we've actually now done quite a big dive into the totality, and there's probably 60 to 70 patients a month going through just to get wound dressings, and that then takes an urgent treatment centre appointment for a planned procedure. And so it's been quite useful, because if we could free up that number of slots for urgent treatment slots, not wound dressings, that's positive. So that was an unintended consequence of the visit, but we've got a whole set of work going on as a result of that. So that was kind of one of those where you ask a question, you get an answer you don't expect, and actually it's been quite positive. I'm not saying we've got the answer, but we actually have now uncovered something which we didn't know previously.
Good, well that's really encouraging if there's action arising. Ross, there's the flag up about better communication with the local community about what it used to be. I know we've done a lot with North Tyneside on this, but any response?
I think it's a perennial one. Right on the country, and anytime we asked them on the North Tyneside piece specifically, we had a scrutiny committee, I think it was last year, we did a whole series of interventions with the council, with ourselves, and trying to get that information perhaps in places where it wouldn't normally be, but it's an ongoing challenge, and we'll keep looking at it. But lots has been
Yeah.
Yeah, I just wanted to acknowledge the performance of our urgent care centres in the national survey. So we did phenomenally well. We were top in the country. So I think that is, vast improvement on last year. We still did well last year, but vast improvement. But actually, to be top nationally in the urgent needs to be acknowledged and celebrated for the staff and our patients.
Good, thank you. That's good to have had that insight into how it's operating. Good to hear that some of the issues raised are being pursued one way or another. Katie, you went to Sexual Health Services Ward 9, Temple Everley at Ward 9.
Yes, did. So big thank you to Marion. It's another really interesting walkabout just to try and see some of the services which don't get quite as much coverage as they should do. So it was really, really interesting. So as you say, they've moved recently from Charlemont due to the facilities there. Ward 9's been set up as well as it can be. It's quite a walk from reception. People are going for confidential, private support. So it did feel quite clinical, but they've done what they can with Ward 9. We had a long discussion with Michelle and Gillian, who have been there since it started in 2004. It was so interesting just to see the vast range of confidential and private and free services that they're providing now right across the North Tyneside and North London. It was also really interesting just to understand how our habits have changed. So they're seeing a lot more men now, older generations, not all married, quite so. So it's really interesting just how they're sort of getting out there now to a much greater demographic, which is good. They were pleased in some ways with being in Ward 9. They felt closer to the trust. A number of the teams are now engaging with them who didn't previously. They're closer to the labs and it's a lot more efficient. But they're not out in the community, which is key to them. And that's what they want. And they're desperate to get back to Shiremore. And if that isn't feasible, they're desperate to have that plan B in place and to be made more aware of the timing of that and how it's moving forward. It was lovely to hear just how innovative the team are, and they're always coming out with different things and different ideas, which was great. Comms has been really helpful in updating their website, which was really accessible and interesting read to see. They started a new C card, which was great. So that's the condom card, which goes out free to those who need that support. They also do a home test kit, which is just brilliant, but they just don't have the resource or the time to do that as widely as they could, and a lot of people are asking for that support. So again, it's whether we can think through what support from the person within Seaton Devil could help to expand and move that forward. So it'd be really worth thinking about that. Also from sort of a comms perspective, as I was saying, they're reaching out to different demographics now. It's not just those who are young. So it's again thinking about how we can make sure they're being heard and people are aware of the support that's available. It was also interesting when we were talking to some of their colleagues. They'd never heard of what a non-exec director was. So we had to explain what the role is, and I think it's getting out there more to the teams that we don't talk to enough. I think it's really important that they know our role really important. But yeah, it was fantastic visit, and we're off to Blythe, I think, aren't we, soon to see the other.
Great. Marion, anything to add? In particular, Katie's kind of set out 4 or 5 things she's hoping we might respond to in some way.
No, so the team were thrilled to meet with Katie, and I think the videos that people have recently done about the non-exec roles has been really welcomed. So we're dealing with all of them. I think it is about getting back to Shiremore, and we know that the other day that we decided just to put a pause on that to have a look at other things. So I think that will be the most important thing. But I think for me they've integrated very well with the team. You know, this has been a service that's been on their own for a long time. And then finally coming into the hospital, a different environment. They've actually worked extremely well together with that. So I think we can just support them, and I think it is really important to go to the places that people don't get a lot of visitors, because they really do feel, it makes them feel part of the trust, but it also makes them feel valued and listened to, which Katie certainly did.
Great. I think we previously agreed that we would make sure that we include some backroom services. I don't think sexual health Ward 9 is backroom service, but nonetheless, let's make sure when the board walk about we include some like that. Forgive me because I was distracted by that. Were you able to respond to the idea of the business, developing the business plan for STI home test kits that Katie?
Yes, that's all in hand.
Okay, that's great. Thank you. Any more on that one? Katie, thank you very much indeed. Next one, Phil, you had fun at Alnwick and Berwick with the car park.
Should we call it fun, Chairman? I didn't go there, yes. I think just to, 2 for the price of 1 this time around, of course, Alnwick and Berwick. Again, just to thank Marion for giving the 2 site visits, the travel time, the car parking time, all added together to make pretty much a full day, I think it's fair to say. So, very much appreciated that. Shall we get the car park issue out of the way first, and then we'll talk about the hospital? So, Alnwick first. I think the car park situation was one of the worst that I've ever come across, quite frankly. It was dreadful. I mean, aside from the fact it took me a long time to park, every person we spoke to at the hospital and outside would comment on how difficult it was. And it really is a difficult situation. There were cars parked all over the place, on the grass, on the pavements. I think some of them might be in the hospital if we'd let them. And it was probably made worse by the fact that none of the pay machines actually work, and they haven't worked for some time. So I suspect it may well be that people are rocking up and parking there all day. They might not even be going to the hospital. So I do think, aside from the fact that we're losing income, if you like, the key thing is I think we need that control in place, and that might alleviate some of the pressure on the car parks. But it's also a problem for the staff, because a number of them who pay for car parks, for instance, then can't park the cars, which seems really unfair. So I do think we've got to get that sorted.
Let's just stop on that one before you've raised anything else. Sorry, was that your hand up? Okay, yeah.
Yes, thanks, Phil.
You're welcome.
And it wasn't new to me. I did a visit a few months ago and had exactly the same problem, so I have significant sympathy, and I did take it back to the team, so they were starting to look at it, but it's fair to say I think we'll push it further up the agenda. Something she always and I won't go into all the details of why there are particular problems on that site. It is a difficult site. It's not one at the moment that it would be possible to have a barrier on, so the issue about how we wanted to use it, a staff car park, is it not, is a bit more tricky. We've got the GP practice there, and there's been issues about what their expectations are, about where they should be able to park from the staff and a patient perspective. So it's not a simple one to fix, but having said that, I think there are things definitely that we should be doing. I've gone back to the team again about it. As I say, it's boosted up their agenda a little bit, so we'll definitely be keeping an eye on that one there, because I exactly know what you're describing, because I did the same thing a couple of months ago. So, like I say, on our agenda, we'll come back to you with some more detail about what the options are, which may be short-term and longer-term issues about that site, which means what is the right thing to do in the interim, but I think there definitely are things we can do in the interim to improve it. A lot of what you said is right about perceptions about when anybody can just pitch up there and park. So, yeah, noted, thank you, and something will happen.
As you know, I also had the same experience when attending the governors there, who voiced a similar view. Okay. So we will hear back in due course. I know executive colleagues will make sure we do. Anything else occurred to you on your visits?
No, that was all. Shall we move on to the hospital?
Yeah, thank you.
Things vastly improved. So I think it was great, good, warm, welcoming reception. I mean, as soon as you walk through the door, the reception is there, so it's really quite nice. And there were a couple of people there that we had to chat to and so forth, all very friendly and welcoming. So that was a good start in the hospital itself. We first went along to the minor injuries unit. It looks like a great facility. I mean, it's obviously an old hospital, but inside it's still very clean, well looked after, so that was really good. The MIU, there were a lot of people in the waiting area for that. It's a much in-demand service. I spoke to the team, all of the team that were there, all great. The issue we've got is that because of some of the staffing issues, it's often not open. And what that then does is create a demand problem either elsewhere in the hospital or in a number of cases on other sites. So in addition to that, it's obviously the patient experience. So if you turn up there and then you say you've got to go to one spec or somewhere else, clearly it's not great that that happens. So we talked about what's causing it. There were different views. One was around, can we do more flexibility, particularly for senior staff and so forth, senior nurses. But I think it's something we need to look into, because apparently there are a lot of minor injuries in AMIC, which is something to do with the fact there are quite a lot of outdoor activities. So that's why there's a big demand. So if people only did that on Monday, Tuesday, Wednesday, it would be fine, but we need to try and see if we can get a more consistent service with that.
Phil, I'm starting to get twitchy about timing, just if I can keep you fairly brief.
All right.
I'm sorry about that.
Should spend it all in the car park. The district nursing team discussion, good team, came across really well, good working relationships. They said like more pool cars, which I think everyone seems to ask for that, and so forth. But they overall, few things that they would like people to look at, but on the whole, pretty good, doing well. They did raise this issue about, on the acute discharges, whether the information given to patients was consistent with what service they then received. And I think there was an element of potential overpromise, and maybe we just need to look at that as part of the discharge process as well. They talked about increasing complexity of patients, and that's something we might need to think about in the context of how we look at productivity. But overall, for the hospital part of it, really good. If we get MIU open on a more consistent basis, that will really help and fix the car park issue, which Veronica's promised to do. I think that's what you said. Moving on swiftly to Berwick, where I managed to get parked straight away. I mean, it's obviously when you go there, it's all about the new hospital, so it's quite a different visit in terms of, yes, we looked around the existing facilities, but everyone just wanted to talk about when the move was going to happen and all that kind of stuff. But you know, the existing facilities, obviously they're old and so forth, but they look fine, they were still kept clean and so forth, the staff were great. So again, very positive. The district nursing team will move into the new site, but currently they're on the other side of the town, so they feel a little bit kind of removed from the trust. So I think that would help when they actually move. They also asked for more pool cars. They have only got 2, which felt quite low for the size of the team, so maybe that's something we could look at. Made a few points about the comments of support. I think the out of hours in particular, that we'd like to see if it's possible to have more on that. I think it's 4 nights a week we get from that at the moment. There's a NIAS paramedic permanently on site at Berwick as well, which is really helpful. So that might be again something to think a little bit more about. But you know, the talk about the new hospital was prevalent in all of the conversations that we had. Just an interesting point around the temporary ward facility that's put in place. It really is excellent. I mean, you have this view about it, oh, it's going to be a bit of a porta cabin and so forth. Well, you know, it is definitely a great facility. And I think when obviously we move out of that, it would be good to see what other options we've got to use that for, because you know, the patient feedback on it and everything was great. I think they were the key points. Maureen, is there anything that's I've missed out? We'll talk about the car parking again. Okay.
Nothing more than that. Pool cars? Any response on the pool cars request?
Yes, so Terry's looking at that to see if we can do things. I think what they felt was, could we swap them with the hospital, but the hospital use them for other things as well, so it's just making sure that we've got the right amount there. And just the other point, the staffing is a worry in the north. It is difficult, sometimes it's easy to recruit, but it's more difficult to retain, and particularly when we're so close to the Royal Infirmary and or just general, particularly in the Berwick region. But I've asked Elaine Henderson as part of the recruitment and retention that she does to work with HR, and they're already starting that piece of work, because we need to just make sure, particularly from a nurse practitioner level, that we don't want to have a new hospital and not have the staff that, you know, we have had time to sort out. So she's just starting that work now with Anna and with the team at both Anna and Berwick.
Very good. Thank you. Any comments? Thank you for that visit and some useful actions arising. Steve, I'm a bit conscious on time. Just
Okay, yeah. I went to NSEC with Jeremy. We visited the ambulatory care unit, and it's fair to say it was different to Andrew's time. It was a quiet part of the day. It was mid-morning, but it was very calm at both emergency department and once we went through into ambulatory care. Interesting on the points about how we describe in the Health Watch feedback, you know, what happens in wards, that initial view of what people see and get and what they can expect. I thought there were some fantastic graphics in ambulatory care and in the emergency gynecological area doing exactly that. It's about the length and height of that wall, showing a really nice flow of what to expect, how long to expect to be there, what happens next. So I think there's something in there that might be worth looking at. It was quiet. The staff did not seem busy, I have to say. And that's not to say that they wouldn't have been busy at other times of the day. I completely get, you know, it's just a snapshot. But it did make me think, and just thinking about Joe's stuff from the staff feedback about how just a small change in the staffing complement can affect their perception of the quality of care they can provide. Whether there is something a little more dynamic that could be done just to respond, just to help fill spaces elsewhere when that's required. One of the main things we wanted to do on the visit was just check out our team's perception of how the front door service is affecting them in terms of streaming. I think it's fair to say everybody was largely positive. There was just one bit of feedback that I think we need to consider, which was about our orthopaedic consultant, the fracture clinic. He had lots of views and thought there could be some learning to help the people at the front end who were doing the triage, looking at those x-rays, to better stream and assess those x-rays, because he felt his time wasn't best utilised looking at a lot of x-rays that perhaps weren't necessary. I think that's probably all I need to say. Just, yeah, good feedback on the front door. Just trying to find a way to bring that feedback loop in from our clinical teams to improve it all of the time.
Jeremy?
So it's really good to have the urgent treatment centre presentations at the same time, because it's not just all of the front door NSAIDs. So actually, a lot of these x-rays will be taken by nurse practitioners in our minor injuries units. And then what happens is the x-rays get fed on to the fracture clinic. There's an open access by the virtual fracture clinic. So all of those x-rays pretty much then get reviewed by the consultant the next day. And there are very few fractures on them. So one of the real issues is that feedback loop is actually, it isn't just in the same hospital, it's in a different part of the county. So that's the sort of system that we've now got. We've got fantastic minor injuries unit. People can present with loads of stuff, but one of the ways that we manage risk and support the clinical staff on is by giving them access to senior supervision through things like the fracture clinic. But it's something that if you look 20 years ago, wasn't there at all.
Thank you. And any response to Steve's exploration of what do we do on the rare occasions that probably are there, where we've got loads of staff and not very many patients? Is there anything?
So I think this is really tricky.
Yeah.
Because the flows into the building can be quite unpredictable, and if you have the difference between, you know, if absolutely loads of stuff around and completely overwhelmed can be only 4 patients, for instance, in an emergency gynecology setting. And that is really tricky, and one does get a sense that what happens at the big, and we'll hear from Simon about the front door, but what happens at the beginning of the day in NSETCH is work that appears later on in the day in other parts of the system. I went back to ambulatory care or another business later on in the day, and the board was just full. And it's how we can do that and run and have access to all of those things. It is quite tricky, but I think it's a good point.
Alistair and then Legion.
I think there's something also about psychological resilience. If we expect teams to pick up when things are busy, if we then just cast them aside when things are quiet, then that's a zero-sum game that will burn people out. And actually having some downtime, if it is quiet as a team, is actually something that we need to use constructively for that team. But I don't think it's wrong that unless we're going to match every time we have a surge, we wrap a whole load of new doctors there, which we will never be in a position to, or nurses. So we need to look at the ebbs and flows and actually allow teams to not feel guilty if it's slightly quiet, but to be constructive in what they're doing. And I think the focus should be on what are the constructive activities that they can do as a team, rather than feeling that it's a bad thing if they've got quiet spots.
I think that's a really strong response. It doesn't fully address Steve's concern that it might look bad to the one patient in the waiting room and there's up to 8 staff sitting behind the desk, but I think that's a pretty robust response.
I think it was just that point. I think there is something about perception as well. So actually having, and it's not the only place we see it at times, rare might be, but in ED where you might have a whole group of staff what appear to be just standing around chatting. They're not. Sometimes it's work, sometimes it might be, and actually there's just a thought process about how that might look to a patient who's waiting.
And I think it's not just about individual patients, it's dual public. Generally, there's a lot of scrutiny, isn't there, on the system at the moment.
Good, okay, that's great. That's been a really useful set of board walkabouts. Went on a little bit longer than I planned, but that's because it's so interesting and so many good ideas coming through. But now we're into the performance section, and we've got a presentation from Simon and Marcus on the medicine and emergency care business unit. Over to you.
Thanks very much.
First slide just gives a bit of an overview of the business unit in terms of services and general activity. One of the key things to note there is that from the bed base point of view, so our bed bases that we've increased the bed base by 27 beds overall, with the opening of a new ward at North Tyneside, taking us to 638 beds now. Looking at the elective performance, so I think certainly what to be proud of here. This has been strong for us, with improvements with ASIs and advice and guidance requests are going up as well, and the outpatient appointment do not attend rate is very stable, but we are doing a bit of work there looking at those particular DNAs and what type of appointment it is, but overall that's strong, and we're doing a bit of focused work around the cardiology, endocrinology and rheumatology as well, just looking at what we can do in those services. But overall I think it's strong performance and ahead of plan from an elective performance perspective. From an accident emergency point of view, so the graph on the left essentially shows that we've had a sort of year-on-year increase in activity across the trust, and we, from a performance point of view, so these are the graph on the right just shows that performance. So I think it's fair to say it's not where we want to be. From around March time, we did see a steady increase in performance. It has been a challenging last couple of months, and I think we have seen that dip down, but what we want to see, particularly the front door, which I'll talk about in a moment, is we expect that that should start to improve. There's a lot of work going on within the emergency department and across the system in terms of looking at improving flow and working with ED around some quality improvement initiatives as well. So there's a lot of work going on there. So it's not where we want to be at the moment, but we're expecting that will improve. Just a bit of talk about ambulance handovers. So you can see from the initial one in the top corner on the left there, so the number of ambulance total arrivals has increased. And to draw your attention to the handovers of 60 minutes and over, which our target is 0, and we've seen there's a lot of work going on around that, and despite the increase in arrivals, we have seen a steady decrease in that. There's been a slight uptick recently, again with sort of the pressures we've been experiencing, but with the what we expect to see is with the new ward we've opened and some of the work around the front door, we're expecting to see improvement of that. But if you look compared to sort of October, it's around 2023, it was about 109, and it was 60 in October. So there has been again that decrease, but again a lot of work going into to improve that. This is how you came in there because you talk about the front door. So this is the front door initiative we started in September. So again, making sure patients get into the right place at the right time. And this is just some of the some data just showing where patients who have been streamed through this service and where they end up. So you can see that 35% end up in ED, 41% in the same-day emergency care, and then there's some other dispositions there. And I think what's interesting is if those patients are there streamed into our assessment navigation service, that's when they have a short consultation with a senior clinician. A significant proportion are going home, and certainly it feels like from our work in the ambulatory care, the same-day emergency care unit, it does feel that we are getting the right patients there, which is really good. So I think there's some challenges there around how we're staffing it, but I think overall it's been a positive intervention for the site, so that's been good and positive for patients as well. Just an overview of workforce. So again, from a sort of sickness point of view, so slight increase recently just as we're heading into winter, but the turnover rate, so after COVID, the turnover rate was quite high, and we've been seeing that coming down steadily, which is really positive, and strong in terms of the learning and development indicators there around praise and information governance, etc. And just from a national survey response rate, so that's the latest data, shows as a business unit, I think this is from Monday, we're at 62.2%, so improved from that perspective. In 2 more days, yeah. And from a staff experience point of view, so the business unit is in the green line and the trust average in the dotted blue line. So I think generally, consistent with that. And again, we are cognizant of this, and we're keen to, we're in the process of doing some work, but particularly looking at those domains which are scoring lower overall. So looking at teams and see what we can do with those areas. So there's been ongoing work around that. And again, what we're going to see is that improvement, but looking at this very, very closely. And just to sort of summarise some of the sort of key achievements, I won't go through them all there. You can see them listed, but we're in terms of the new front door and the new ward we mentioned, and the refurbishment. So we've got a flow improvement group as well, which is set up. And as well looking at some of those quality improvement work across both at NSEC and the base sites as well. The assessment centre has been successful as well. So a lot to be proud of there. And in terms of the sort of key actions going forward, well, as I mentioned, we want to see that performance, the improvement in ED performance, the ambulance handover, and reducing corridor care with the aspiration that we will to have zero corridor care in the emergency department on the wards, and that's what we're aiming to do by improving flow. And again, continue to develop the shared front door, and really focusing on a patient and staff experience. Want to continue to deliver strong ERF performance, and again focusing on those specialties I mentioned, particularly cardiology and rheumatology. Increased capacity for the pump program in diabetes as well. And as well as anything else, I think it's just we're keen to sort of embed and grow that quality improvement ethos in the business unit, because I think that will unlock a lot of this in terms of flow and performance. So I think overall, just summarising, so I think we are expecting this could be a tricky winter. I think we're seeing an increase in RSV and flu, but I think we have a strong plan going forward. I think again the teams continue to be amazing, and I think it's the challenge for us in the business unit is how we're looking after our the staff and the teams as well, which is ongoing kind of concern and looking what we do to support them all the time. And I think I think there is a lot to be proud of in the business unit, but I think we're aware that there is still a lot to do. And while nationally we're still performing extremely well from an emergency care point of view, we are not where we want to be, as I mentioned. So again, a lot of the work focusing on that as well, and just sort of keeping that momentum on service ambitions and innovations as well.
Great presentation, Simon. We've been giving a lot of attention to all this work over some time in a range of committees. Jo, and then Phil.
Yeah, it's just a comment really. I met with Health Watch yesterday, Derry and Paul from North Tyneside and Northumberland, and Paul asked me to share with you that just informally we've got quite a number of patients around who he believes have gone through the front door model, because some really positive feedback, so we wanted me to share that with you.
That's really good to hear, thank you. Yeah, that's really good. Thank you.
Just wanted to add, for those that weren't there, we did have a really good discussion and presentation from the team at FIP, in particular just focusing on that issue about the increase in demand. I think it's flagged at over 10.5% here, and we've asked the team to come back towards the end of the financial year, probably about March time, partly just to see what ongoing impact the front door measures are having, but also to analyse that demand picture in terms of people that get admitted versus the ones that get turned away, and just try and understand that underlying position in terms of the demand.
Very good. I've got Chris and then Alison.
Thank you. This is less of a question, more of an observation. Nationally, we hear quite a lot about patients can't access primary care to the particular front doors of EDs. But if you look at your diagram there, the percentage streamed and through the ANS service that don't sent back to GPs is 2%. So that narrative doesn't necessarily hold in this circumstance with these numbers.
That's absolutely right, isn't it, Alison? Yeah. Your additional point?
It was just about the advice and guidance. I'm just conscious that we might be getting a false perception, because advice and guidance is now the only route by which patients can be referred. Do we need to subtract referrals from advice and guidance? Because there's a danger actually we're double counting, as in things that would have been a referral previously, we're now counting as advice and guidance, but that's not an increase, that's just actually a change in the way that we've asked primary care to initiate things. So it would be almost impossible for advice and guidance not to increase if we've closed down direct referral as a route. So it's just making sure that we make sure that we're not getting an increased baseline where actually the activity is static or possibly even decreasing.
That's a powerful point, because actually the rise was extraordinary in ANG rates, particularly given where we are in the collective action.
I think there is an increase, but I think it's worth just subtracting one from the other just so we get a really accurate point.
So just on Phil's point, I wanted to highlight the ambulance attendants, because I think we've been singled out as a region where our ambulance attendants really are bucking the trend of either being flat or going down. We've had another, in the last 2 years, on top of 2,800, an additional 600 odd ambulances coming in. So I wondered if there was, because we've got a front door model, whether there was any thoughts about a back of the ambulance model, because I know that not all of them don't necessarily end up on trolleys, and some are fit to sit.
Well, we do street, that Mark's movement, we do take some to ambulatory care and SDEC from the ambulance corridor, so the team will do, we get quite a few diverted around to us when they come in the front door, and we do take referrals from the NIAS as well to come direct to ambulatory care, but I know Mark's soon coming.
Yeah. So it's a really good question, Jeremy. I think we need to be really bold moving forward. So the things that we've done with the front door, we absolutely need to do to the ambulance corridor as well. So some of the increases, myself and Chris with the ICB, we've got a meeting on Friday, that increase is probably more apparent with ourselves compared to some other areas. So we're looking at things like how can we intervene a lot earlier, so before patients even get into the ambulance system at NSEC, can they go to the EAC, LD assessment at one spec, working with community to try and divert for the 2-hour response. There's a whole lot of work we need to do to try and, it's exactly the same way we're doing with the front door, reduce that trend coming in, because there's a lot of patients who know from some of the data that they aren't actually admitted. When they come in, they're actually relatively quick turnarounds. So there's a definite area in there, I think, for opportunity and improvement.
Okay, really good presentation. Very positive. Good to hear some extra feedback, asking for the clarification on the data, particularly the but seeing that the front door is having a positive impact, but we still need to explore all the implications of it and the consequences. Thank you for your presentation. It's really great. Now, as usual, Ross is having to do a sweeper roll. In other words, we're running a bit over time, which we always do. So can we please just look for at least one public book? Can we bring the comms further forward on the agenda for next time round? But meanwhile, Ross, do your normal, please.
Thanks, Chair. Yeah, very conscious of time, so I won't roll this out. A couple of things to note, I think. Just to link in with what Evie said in her introduction, it's a really strong performance in terms of perception and coverage and all the things we measure, which is not the same nationally that I hear very regularly from colleagues when I meet them from other trusts. I think the thing we're hearing in public sector communication, certainly at the minute, is that the key battleground is around trust and people trusting the messages that they're hearing. So as an OECD survey out at the moment, the UK has the lowest levels, third lowest levels of public trust of any country. So about 60% of people have no trust in what public institutions are saying. So that's a real worry, and you'll notice on the dashboard now we're measuring trust and sentiment. So we've got some new technology in place that's helped us do that. It's early days, and I think we've always been very good at looking at outputs. This hopefully lets us look a bit more outcomes and do this some real intelligence. So we'll keep a close eye on that trust measure and on the sentiment measure as well, of what people are saying about it. Everything going well in terms of the channels. One thing I will mention, and I do mention it most times, I think the last 12 or 18 months we've had a real pivot to video in our communications, and what we see is with low staff and the public are much more likely to watch a 2-minute video than they are to read through, as you will probably only realise after reading the material. We're really sort of getting good at that now, and you'll have seen Andrew hopefully in a video last week talking about tech, and there's a whole suite of different things, and some of the stats and figures are really impressive, and I hope to bring that issue in a little bit more detail. I think maybe more development at some point in the future. But other than that, I'll leave it there. Good story. Good coverage.
Thank you, great report. Any questions or comments? I'll be really interested to see how the trust indicator moves. Good, excellent. CQC regulation to receive, this feels pretty straightforward, am I right, Ross?
It is, yeah. I'm happy to say we're all compliant, and it really just builds on a lot of the things we talked about. This is the one that's the kind of joint effort between Joe and I. And the thing that I think is the return and the real positive experience around face-to-face engagement, where we're really, I think, getting back in our stride in that after the pandemic, and it's becoming much more regular, and much richer as you've demonstrated as well from the governors.
Any questions or comments? Are we happy to receive this? Okay, thank you. We're into that section of items for escalation, so although there's lots of papers, we'll call in comments. All of these have been chewed over by the relevant committees. So, Marion, first of all, the nursing and midwifery staffing and assurance report for October.
Yes, I think everybody will have a good chance to read through this. The key things I wanted to bring up was it's been a very busy October. I think the staff moves have gone up that we are really looking at. But I also wanted to share with you, and Marcus and the team are doing a lot of work on this in the background with everybody else, is looking at corridor care. And that comes back to basics, to a very regular report just now, which we will be sharing with you in due course, but just to reassure the team that we're on this. And exactly the same with the HPs. You know, a lot of movement this month. I think the HP dashboard is coming along nicely, and always very happy to take any suggestions or comments about either of these dashboards.
Okay, then we just discussed it. People and culture and at safety, is that right? Yeah. Any comments, Alan, from the safety that want to highlight on this? On the assurance reports? No? Straightforward? Okay. Good. Or anything from people and culture wanted to raise on it?
The
No?
assurance report doesn't come to me.
Oh, this one doesn't. Okay, I beg your pardon. Okay. Then we're into the learning from deaths, Jeremy?
Yes, just to advertise the great work that continues to be going on by our clinicians. More training this week. We had a very good learning event earlier in the autumn, and particularly focusing on the last year of life, which is going to be of great support to the board that's dealing with the strategy. But we continue to develop a good team and a good process to support our safety strategy.
And once again, this has gone through safety and quality. Any further comments or issues? No, thank you. Then, Chris, over to you for the corporate safety and quality.
Yeah, thank you. I don't propose to go through each measure line by line. I think just overall to say, Chair, that there's strong performance across the most domains, most metrics. Just a couple just to highlight that have changed with the validated month-end position from when we submitted the report. And that's the RTT, the 52 weight position. For October, went down to 34, not 35, so that's positive. And in terms of cancer, I think Bijou alluded to it earlier on in the meeting around the 62-day cancer performance for October, looking at 85.2%, which is above the 85% target.
That's two terrific pieces of news. I know this was chief over at finance and performance as well. Still anything to highlight or have just received? No. Okay, that's great. Then Paul, it's over to the corporate finance report.
Chair, the report was discussed in detail at the Finance Performance Committee. I'd just like to highlight the issue in the month has been the underfunding of the National Key Award, and we're having discussions with the ICB and other colleagues around any resolution to that funding shortfall.
Phil?
Just to add, that's a common issue, I think, across the few trusts, and therefore we're not alone in obviously trying to seek a resolution to that.
Okay. Anything more? Then that brings us into the end. We need to just approve our best guess as to what the agenda for the next meeting is going to be. Anything anybody particularly wants to throw in before at the last minute we throw in a few extras where we normally do. It's okay for now. Then review of the meeting. I'm really struck. I squeezed a couple of people. I squeezed Steve in particular, yet we still ended up 10 minutes early. So apologies, Steve. I should have squeezed you. Jeremy.
So I did have a bit of AOB, I'm afraid.
Oh, right. Okay, go on.
I didn't ask it earlier on.
Yeah.
So I just wanted to highlight the issues that are affecting some of our medical associate professionals. There's a lot going on in the national press, and there's some really quite troublesome debate going on, particularly around the anaesthetic in the GP college. But just really to say that we have about 25 of these professionals. They remain well supervised and supported. We've got good guidelines in place. We're very content that they're all working well, and I wanted to assure the board and the public that they have our support and they're working very well in Northumbria Healthcare. There is going to be a review of the grade by Wes Street, and if that causes a pause in some of the troublesome activity in and around the press, that will be a good thing. We're very keen to contribute to that because they're a valuable source of support for our patients and our services.
As a board, we continue those roles. We considered those roles some months back and decided that we're giving our wholehearted support to it. We shared it with the governors, who also underlined their wholehearted support for the programme, recognising it's important for the roles to be clear and for patients always to know who it is that they're being seen by. And I think we've supported the idea that there should be regulation for these health professionals, as there is for pretty well everybody else around. So maybe it is timely for us to reassert our support for these important colleagues within the trust.
Thank you very much.
Seeing nods around the room, if anybody wants to make any additional points on that. Steve?
I just want to say that the bit I got squeezed from the board walkabout was actually just to recognise the pastoral support that Jeremy provided to that physician associate in the ambulatory care department. And I thought we made it really, really clear that we're in support of them and we've got the back, and I thought it was just really, really good to see.
So just contrasting the very clear vision that we have for those group of colleagues and the confidence that we've got that we're in the right place with the complete mass confusion and national dialogue on it, is there an opportunity for us to contribute to the review, and will we take it to be as proactive and assertive as we can?
Very, very, very much so, I hope. I'm very keen that they speak to people who work with them, and certainly I can tell you from my own experience, we're heavily involved in trying to influence the anaesthetic college, but a lot of what has been written is on the basis of people who have never worked with people from this grade.
Okay, so we will not only reassert our support, we will also make clear that we will make a strong submission to the National Review. Back to the review of the meeting. Has it given people, colleagues, the opportunity to raise any issues that they'd intended to? Then I think taking silence as broad comfort. And thank you, colleagues. We reconvene in 35 minutes, and there's lunch will be available. We'll be coming in just shortly. Thank you very much indeed.